I love being part of this gang. It's so inspirational to know so many great people and international people. So my talk, I'm a clinician. I work in the National Health Service in the UK, 60 miles south of London. So we're in the southeast corner in Kent, and it's quite a big service that I work for. My specialism is in dysphagia, and I have a lot of children who are very unwell and have a lot of high need. The issue for me is that I have developed my specialism, and everybody wants a piece of me. So, like many therapists and clinicians, I don't have a lot of time, and I'm always running. And speech therapists who love to talk, we're always late. I've started off late, I think. Okay. So this is a case review. I am very interested in tongue tie and tongue tie and swallow function. And part of my clinic, I do lots of videofluoroscopies looking at swallow. And historically, working with a respiratory consultant, he said to me one day, why do we have so many children who are aspirating who don't have a neurological issue? And so I set off on my journey, and as a speech and language therapist, we're always thinking about muscles and function. And I came across Samantha and Joy's course, and from there on in, I have real passion to take things forward and to bring myofunctional therapy to the UK, because I'm shut down. You know, I know a lot of consultants. I've been in the NHS for 28 or 29 years now, and I'm becoming a pain in the backside to my colleagues. But I don't care now because I have to support the patients in the best way that I can. And I think that when we meet mums and babies with problems and how stressful that is, and we need to do something about that, because if you can't feed your baby, that's a real problem. So I'm going to take you on a whistle-stop journey. And here we go. Okay. So I wanted to start off by kind of linking information about swallow. I have, I don't know if that's light, no, it won't be. Okay. That's okay. It won't play. I had a brilliant YouTube clip of the development of the face in the womb, and I think it's really important when we're working with little ones. And from Michelle's presentation, you're thinking about what happens in utero, so this clip just kind of highlighted and gave a very dynamic picture of the development of the face, but you can have a look at that on YouTube. Okay, so the development of the swallow mechanism, it's always good to revisit this stuff, and I think that I've been practicing a long time, but I'm always learning about anatomy. It might be that I forget things, but it's kind of building on existing knowledge. It's thinking about, you know, where tongue tie happens it's happening as the development happens. So it's happening in utero. And we're thinking about, you know, at 4 to 6 weeks, you have the development of the face. At 9.5 weeks, perioral stimulation yields mouth opening. 10 to 17 weeks, the baby's regulating amniotic fluid through swallows starting to appear. So it's a key time. And when I meet with mums and we're talking about birth history, you talk about, you know, how was the pregnancy? Did you carry excess fluid? and quite often some of those babies, yes, the mums did, and it's thinking about that relationship between the tongue function. That's how it started off. So at 28 weeks, we have rooting, sucking and swallow reflexes present, and the sucking of hand or thumb, and by 32 weeks there's the gag reflex, and non-nutritive sucking is starting to become really established, and functional suck, swallow, breathe is evident. 34 weeks you've got cough emerging and protection for the larynx, and by 36 weeks there's a coordinated nutritive suck and lung maturation in preparation for air and breathing. So I have my caseload is working with neonates right through to children and young adults through to 18. But my predominant work is with the 0 to 3 years. Okay, so we can't play this either. No worries. Okay, so so tongue tie is present at birth, and we all know that it restricts range of tongue movement, and it's a short, thick or tight band of tissue that tethers the tongue. I hope it plays. Yes. Okay, so just to show you a normal swallow, and I'm sure that for the speech language therapists certainly who are in the room, you know about swallow, but for swallow it looks like when it works effectively, it works in one coordinated action. No, it's me. There. So just to show you the neat transfer of material through the 4 stages of swallow. So through from tongue, the oral preparatory phase, across the oral phase, pharyngeal phase, and through to the esophagus. So there's no problem. But to understand swallow function, we need to break it down. We need to look at separating out at what point is the difficulty. Why does a child or an adult have issue? So just to, so we have this one when it doesn't go so well. So down into airway. The muscle forces aren't doing their job, and we're looking and thinking about aspiration. So as children are referred to me, and I see complex children, so children who have high level of need, failure to thrive because of issues, poor respiratory health. And my job is to rule out aspiration. Is the food or liquid going down the wrong way into airway? Okay, so swallow involves a complex series of voluntary and involuntary neuromuscular contractions to allow the safe passage of food from mouth through the pharynx to the esophagus. And these little girls, they're my friends, and you know they're becoming masters of eating. Okay, so the link between feeding and breathing is a system of valves, a system of chambered organs, muscular activity, changing pressure gradients combine to move air and food. And at rest, the valves enable respiration, with the valves changing position to be influenced by muscle contraction to allow for swallow. So you have, as Michelle highlighted earlier on, you've got these muscles working together to create efficient muscular movement to move food through in a coordinated way through the pharynx safely through to the esophagus. So what about tongue tie? Which is the million-dollar question. But we're thinking about the impact of tongue tie on feeding and how does that interfere with sucking and swallow function. And posterior tie, what about the posterior tie? So posterior ties in my world and working alongside my clinical colleagues, it's hidden. It's a hidden problem, and I'm faced in trying to figure out whether a child has posterior tongue tie. And in the UK, we don't have service for tongue tie. I am involved in kind of creating a noise around it, but I have the advantage of doing swallow studies, so videofluoroscopy, and can show images to kind of push that forward. And while for me, I kind of think, well, you know, you're putting a child under radiation to gather those images, but actually it's about gathering the evidence and sharing it so directly and visually so that people can see what's going on. Okay, so this exercise is to take your arm across your body, hold your sleeve tightly, and with your hand holding your sleeve, try to move your arm. Okay, so very simple, but that's the tongue struggling to coordinate and contain a bolus. And when we're thinking about tongue function, very fine and refined movement to support and contain bolus. And that refined movement becomes more evident as a child starts to wean and progress with their food intake. So looking at videofluoroscopy images is always interesting. I work with a team of 3 speech and language therapists who've been doing the clinic for a long time, and it's fascinating what you see and to see the hold-ups. But you kind of look at a radiographic view of tongue shape and a posterior tongue tie diagnosis that went on to be formally diagnosed, and you have a very high tongue, which was scored on the Mallampati score as a level 4. Okay, so this slide, and I apologise for this, but I wanted to keep it in because this little girl came through to me. She was struggling with her weaning, but as you can see, let's see if this works. Oh no, sorry.
So, while you're fixing it, what do you mean she was struggling with weaning?
So struggling to progress onto food.
Okay.
That's me, it's me. You can't stop, it's okay. I got it, it's me. It's just working that way. Pointer. Okay, thank you. Okay, so we she was a little girl who had aspiration, but why I found like this slide is the actual shape here shows almost like a straight line down to the level of the valleculae, so this area here. So she had no chance of holding or containing the liquid that she was given. It went straight down to this level and then overspilled to this level. So we have here the valleculae space, we have the epiglottis, which is here, and then the pharyngeus and the piriform sinuses here. So that material sitting below the level of the larynx. When you swallow, you have the upward forward tilt of the hyoid bone, and with that, for her, material just went into airway. Okay, so she ended up on a tube and a long wait for a frenectomy. No, it's okay. So this image, the same, no, a different child, but I just wanted to show you this image because it highlights airway irritation, penetration of material into airway. It doesn't go beyond the level of the vocal folds, but potentially gives irritation and responses like asthma. So here, this little guy was had a diagnosis of tongue tie, and this child, I'm going to show you this videofluoroscopy. It demonstrates aspiration of material into the airway. They're hard to see if you're not used to looking at these images, but I'll do my best. I'm not the best controller, but I'll do my best to highlight it. But what you're seeing here is she's taking liquid, is it's going down down the trachea. So, did you see that? Do you want to see it again?
Yeah.
Okay. Oh, no. So you've got small amounts, so that it just happened just there, coming and trailing down. The interesting thing about this little one, who was aged 6 months, was the amount of effort required to accept the liquid. There was lots and lots of tongue pumping to gain a very, very small amount. And so you have all those other issues going on, potential reflux that presents itself as reflux and is treated, but it doesn't make a difference. So yeah, this person, this little one was tube fed to support respiratory health and breathing, and to get their nutrition up, get them stronger, and then revisiting to put them back oral. So the 4 stages of swallow, and I'll whiz through this because you can take away the slides. But when we look at videofluoroscopy, as I said, we're thinking about the 4 stages. So the first stage being the oral preparatory phase, so the voluntary phase of swallow, and it's this phase where the food or liquid is formed into a bolus. So with teeth and an older child, you will be chewing and masticating and breaking down the textures using the teeth. You've got intrinsic and extrinsic muscles and jaw muscles working independently and together to support bolus formations. And you have a really nice curve to keep that food bolus at the front to stop anything slipping back. So that previous slide of that little girl that looked like liquids going over a mountainside, she was really unable to do that, very, very restricted by her tie, her posterior tongue tie. So this chap, Harrison, he was a boy who came to me, and usually when you go on holiday, or the day before you go on holiday, you get the worst client, and I'm sure that's for everybody. So Harrison's mum came to see me, and he was 9 months. He presented with chest infections. I think he'd had one a month. He'd had excessive antibiotic treatment for his chest infections, and his mum was very, very tearful. I think I saw her in my clinic at 3:30. So you know, and you kind of think, oh my goodness, I'm going on leave. But so for this little chap, I sent him to the ward. I did feel that he needed tube feeding at that time to support his airway. My assessment suggested that he was aspirating. But his slides are pointing to high risk factors for swallow. So we have again material collected at the valleculae and at the cricopharyngeus pre-swallow. Again, material collected here is high risk for aspiration associated with the higher laryngeal excursion. And this was thin liquid accepted from a cup, so showing premature spill from lack of oral control. It slid over the tongue. And then you have some airway entry on the next slide, which during swallow there was airway entry, and I'll just highlight that with the pointer. But you've got just in there airway entry, which went on to be a more significant aspiration. So Harrison, he had a suggested diagnosis of posterior tongue tie. His nutrition supported on NG tube, and he was placed on a waiting list at the Evelina Children's Hospital in London for that procedure. And in the UK, because tongue tie isn't particularly considered, it's a little bit like a lucky dip as to who you see. So this young man waited 5 months on a tube before he had his bronectomy. So, you know, serious, depressing stuff. His mum was really beside herself. But the good news is, Harrison had his tongue tie procedure done when I think he was 14, about 14, 15 months. And these were the images post-procedure. But he loves his food. He's had that interest and that willingness. You know, the airway issues he had didn't put him off.
And so then he had an NG tube that whole time?
Yeah. It makes my job really difficult. It's so difficult.
Did you say after the swallow study, when you diagnosed it, you said
He waited 5 months.
He had to wait, so he didn't go into the hospital right away after that.
No. Sorry. Oh, yeah. Okay. And then there he is again, and 3 to 4 months after. Sorry about the music. Okay. So it's a big plus, but waiting so long was really difficult, and let's turn that music off. Waiting so long was really difficult. He currently still struggles with liquid, so he has to have his liquid thickened, and he's on the track.
What food averse?
No, he wasn't food averse. He was always really motivated. Yeah. And it's whether that tube, having that tube, whilst you never want to put somebody enteral, but having that tube, whether that supported him from having those negative experiences. Yeah.
Are you getting the post-operative radiographic images to show?
I can't. Yeah.
And you've already been doing oral facial biology,
Yeah, for him, we were doing orofacial myology and concentrating on obviously lifting, and widening jaw, So the oral phase is the next part of swallow, which is the reflexive part, where the lingual surface of the tongue grooves with midline to drop, to collect and hold the food bolus. We have the tongue tip followed by blade to palate, pushing the bolus into the pharynx, base of tongue to palate approximation, base of tongue to pharyngeal wall approximation. Soft palate seals the nasal airway, and sensory receptors feed into the nucleus tractus solitarius, informing the timing and sequence of the swallow. So you have tongue fibres in the hyoid bone for the lift, and you're thinking about that posterior strength, those movements, base of tongue to palate, base of tongue to pharyngeal wall, as being the driving force for swallow. So if you can't achieve that, you start to have hesitation of a bolus hanging around the pharynx for a little while. And that's one of the images that classic that you pick up, where you see during swallow incomplete closure of the velum, and so you have this line going up to irritate nasal airway, and you also have just a very slight epiglottic undercoating. So there's not complete closure and contraction. So the pharyngeal phase is the kind of key, the epiglottic closure to keep that airway sealed and safe. And it's a single pressure-driven event in which the oral cavity, pharynx and esophagus form one single tube to transport a food bolus. You have velar closure to create pressure, you have shortening of the pharynx, you have the anterior tilt, the hyolaryngeal excursive movement, the anterior tilt, you have upward movement from the superior laryngeal muscles. Airway protection is there, and the anterior tilt of the hyoid bone supports opening of the cricopharyngeus to allow that food to go through to the esophagus. If you haven't got great anterior tilt, you've got hesitation and material collecting in the cricopharyngeus, and people complain, oh, I feel something in swallow, stuff collecting here, and that will be why. So this is another video of a young man who has a tongue tie, and this is a boy who's accepting a melty crisp. So this young man, he loved his food, really loved it, but he wasn't always really safe with it. But it's the tongue tie, the restriction, and how much effort he had to put in. It's smart, yeah. So there you go, and he's got lots of material collecting orally. He needs to kind of do repeated swallows. Yeah, oral clearance isn't great for him. Okay, so I like to think of the team I work with as the Red Arrows, and I'm always the last plane at the back to be called in. I'll see children on the ward, and they, one of my colleagues will think, oh yeah, we'll bring Katrina in, she can have a look, we've got this respiratory illness patient, and Apollo, this young man, was one of those patients. So when I met him, he was covered in tubes, he was on oxygen, he was tube fed, he was needing nebulizers to support his airway and breathing, and he'd had, so his hospital admission as I met him, he had pneumonia, and he'd had a history of recurrent chest infections. He had NG tube feeding placed at rest. His mouth was open with his tongue extended beyond his lips, and he was an open mouth breather. His mum had said that his problems were really difficult and becoming increasingly difficult as he was being weaned. So thinking about, again, moving the swallow up from being far back to the tongue having more control, and those spaces stretching and growing. He had persistent coughing and choking. He really struggled to manage his secretions. And in his history, he'd had frenectomy to support breastfeeding, but I suspect that it had been looked at as an anterior tie and not thinking about what was going on further back. And he didn't have good tongue movement at all. It was very, very restricted. He didn't have a lateral chewing, side to side movement. You know, he's 9 months and walking, okay? His Mallampati visualization was scored up at a 4. So the findings on videofluoroscopy where that pre-swallow, the food texture travelled over base of tongue, separating from main bolus, he lost control, it passively moved into the pharynx, he really struggled to get swallow then. At the oral phase, there was reduced strength of base of tongue retraction, so base of tongue to hard palate, base of tongue to pharyngeal wall, and he had quite a bit of nasal airway penetration, and you would see him clinically rubbing his nose to show signs of that irritation. There was reduced hyolaryngeal excursion, so he had penetration and aspiration, and with tiring there was an increased volume of material noted to go down into the trachea. He always sounded wheezy and congested, and that was very evident during our screen, and he had a lot of throat clearing. And those are some of his images. Oh. So on there again, you see the airway entry going in. Let me put my glasses on. You can see the aspiration, material on the posterior wall of the trachea, and as the larynx came into rest, this emerging dense line. Okay, so he remained non-oral. Our aim was to get him healthy. We didn't want him to have the chest infections and the seriousness that went with those. And he had enteral feeding, he was NG tube fed, and he now has gastrostomy. He is followed up by me, and further assessment by ENT was required. So ENT saw this young man and didn't want to do anything about him. Okay, so we have to play a waiting game. And it's really, really, really difficult. So again, the esophageal phase is the opening of the esophagus, which is influenced by higher laryngeal excursive movement. That anterior tilt is responsible to move material through. There's a positive pressure of the bolus passing through, and contraction of the pharyngeal constrictors supports those pressure forces to support the passage of material through to the esophagus. So the tongue is an influencing force on bolus formation, informing the process of swallow. Each muscle is interdigitated, meaning that the fibers of one muscle interact with the others so they can contract at the same time and support swallow effectively. So it's good to take images of this. We know about the tongue, we know about the fibers, and we know about the muscles involved. So the intrinsic muscles and the extrinsic muscles of the tongue. But when we think about the extrinsic muscles of the tongue on bolus formation, eating and drinking, we're looking at, abnormalities in the genioglossus, meaning that there's difficulties in protrusion, depression of the tongue, transfer of the bolus posteriorly. We've got the higher glossus, scattered bolus, decreased control of formation of the lingual bowl. You've got reduced lingual lateralization, so side-to-side tongue movement, the dominant backward-forward tongue movement, the reverse swallow, and reduced tongue tip movement, so tongue tip to the alveolar ridge, and reduced posterior elevation of the tongue, and reduced elevation of the soft palate, and influencing directly the lift, the anterior hyolaryngeal excursion to support airway and support airway closure. So again, we have these muscles involved on swallow function, suprahyoid muscles influencing hyolaryngeal excursion to support airway closure during swallow. So from the evidence, we know that if range of tongue movement is restricted, that it affects position of the bolus with material spilling over base of tongue to the valleculae. It affects strength of swallow, influenced by tongue to palate and base of tongue to pharyngeal wall approximation. And it affects the lift, the hyolaryngeal excursion, the upward forward tilt to support the epiglottic closure and the opening of the pryopharyngeus. So again, I just pulled out studies, and there are lots of studies emerging looking at the influence of the tongue on swallow function. In paediatrics, I'm sure you'll all agree that the literature always starts in adult world and then comes down to paediatrics. But I think there are lots of studies coming through for paediatrics too. So this young man, Luca, is a young man who, again, he came to me late. He was 16 months old and able to accept puree. He had some of those symptoms, vomiting associated with feeding, and he was being treated with for reflux, and there was suggestion at clinical assessment of penetration causing coughing, airway irritation. He was very dribbly during the day and presented with an open mouth posture, and he had persistent chest infections. So, you know, similar features. It's so we took him to videofluoroscopy, and I'll show you the images. Okay. So pre-swallow, he had poor lingual control of the bolus, so it slipped down to this area before swallow, and that was the yogurt. And it was a passive spill, so it was an unexpected spill for material to collect there, and he needed to try to manage the bolus from that point. And then you have, during swallow, that nasal airway entry of material up into the nasal pharynx. And you think about, again, that poor contraction affects swallow pressure. So what it's going to get airway. Okay. And those are a few more of his images. So again, as the study progressed, that material then started to spill over the base of tongue and to collect low down, and increasing volume. So again, during swallow, it has nowhere to go but into airway. So Mum's journey, and I'll read you what Mum wrote to me about her experience. This young man did have a tongue tie release, so they paid for it privately. Okay. Before the release, Luca only managed smooth purees. Any lumps at all made him gag and choke and eventually vomit, which made all meal times a heart-sinking time, which we literally dreaded. We had started to wean him at 6 months, as we did with our first child, and initially I thought maybe it was just too early. He literally couldn't eat, or more specifically seemed to swallow. There were a lot of tears, his and mine, but we persevered. I had a feeling something wasn't right with him, and to me it felt mechanical, that literally something was stopping him swallow. And the choking incidents could be really, really scary, so we started to stop him from having anything except for puree. Luca had a constant rattling and wheezing in his chest, which was the prompt we needed to get a referral for some advice. When he was 18 to 19 months old, we still had to take purees everywhere. We went. I packed a whole suitcase for our holidays, and I felt very uncomfortable explaining to him why he only managed those. He was always really interested in the food we were eating and always wanted to eat the same as his sister, but we kept saying no, we needed to keep him safe. So they had the tongue tie procedure, and these are Mum's comments and her journey. So after the operation, I hoped for and expected a literal overnight change, and I was initially disappointed, as Luca now seemed to just swallow food whole without trying to or being able to chew it properly. But over the next few weeks, we noticed he wasn't being sick, and he was starting to eat softer tube textures and not just puree. The rattling had gone, and only occasionally do we hear him. Occasionally now do we hear it, and it's not like it was before. Then he was eating more food with lumps without being sick, but it was gradual and we were really elated. I admitted I was so sceptical and a little dismissive and disappointed when Katrina mentioned she thought the problem could be a tongue tie. It just felt so insignificant, and how could such a small diagnosis cause this amount of sadness and frustration? Then I started to read up on it and hear other people's experiences, and a lot of things started to make sense. I had initially believed that tongue tie was checked for by health visitors and was clearly visible at the front of the mouth. I had not heard of a posterior tongue tie. It turned out that Luca had a very thick band of posterior restriction. We're so grateful to Katrina and were so lucky to see someone so knowledgeable about the condition. After 8 weeks, we were in a cafe and I was sitting there with Luca eating cheese on toast, followed by a cookie and an apple. Hard to chew textures. So, it's good, great. Beautiful. This last slide, and it hasn't really translated as we converted it from Apple to PowerPoint, but it's just a summary slide of how tongue tie diagnosis affects swallow function, so across the phases. So breaking it down into the oral prep phase, where there's the dynamic tongue and jaw movement to support mastication of the bolus, leading to the scatter of material. There's reduced lateral side-to-side tongue movement. The bolus position is affected, with the follicular space becoming a swallow trigger. So a low point down into the pharyngeal area. Depending on texture, there's premature spill of material into the pharynx. Risk of choking is increased. And then the oral phase, you have the bolus is not influenced by good glossopalatal approximation, so that affects the strength and pressure of the bolus. And glossopalatal approximation, base of tongue to pharyngeal wall, is affected, linked to the tethering, and you have reduced muscle strength in swallow pressures. So I'll put that back. Do take images. We have reduced base of tongue movement leads to reduced hyolaryngeal excursion. Penetration and aspiration can be indicated, and the reduced hyolaryngeal excursion can lead to post-swallow residue. That residue is then at risk of being aspirated. And the esophageal phase, it's for me, and thinking about the pressures generated by base of tongue to support swallow and the impact that has on the esophagus. And I think that hasn't really been explored or investigated. You often see in children who struggle to get those pressures, they need to repeat clearing swallows, so that leads to a build-up of air, and you get vomiting. So that's me. That's another of my pals. Thank you very much.